in lung cancer. It gives me great pleasure to invite our chairperson, Dr. SH Advani, Senior Medical Oncologist from Mumbai, to give the introduction and context setting. Over to you, sir. Advani, sir, can you hear us?
Yeah. Good evening, colleagues. We have really gathered together here with the help of AstraZeneca for a program in the lung cancer. And as all of us know today, that the lung cancer has become the #1 cancer world over. And I think it is in this disease that there have been landmark changes in the field of their treatment, where initially we started with just a simple chemotherapy with hardly any effect, to effective chemotherapy, followed by the target identification and targeted therapy, and today followed by the immunotherapy. And to discuss all these things today in this webinar, we are lucky to have an international speaker, Dr. Herbert Loong, who is going to discuss with us and give us an insight into what is the progress which have been seen, particularly with respect to EGFR mutation lung cancer. So I would request now Dr. Herbert Loong to give his talk.
Thank you so much, sir. So Dr. Herbert's talk is after 2 talks. So with your permission, we may proceed.
Yes.
Thank you so much, sir. I would now like to invite our first speaker, Dr. Minish Jain, medical oncologist from Pune. This session is sponsored by AstraZeneca. Over to you, sir. Minish, sir, you will have to unmute yourself.
Good evening, everybody. I'll be presenting molecular biomarkers in lung cancer. The NCCN guidelines were first published in 1996, which were updated once a year. There are 7 updates in 2021, which tells us what is the scenario going on with lung cancer. Lung cancer till 2020 was #1 disease in incidence as well as mortality. In 2020, breast cancer has surpassed lung cancer, but mortality-wise, lung cancer still remains #1. And it is actually much ahead of other malignancies causing death. In India, it is the 4th most common cancer, 2nd most common cancer in males. It is the most common cause of death in men, and the average age is 54 years with male to female ratio of 4.5 to 1. And smokers having a ratio to non-smoker as 20 to 1. Next slide. Next. Yeah, next. This is what I just said. Next slide. Okay, so biomarker testing in non-small cell lung cancer. Next slide. We know that non-small cell is not one disease, but a many disease. And we have evolved from histological and molecular subtyping, from histological to molecular subtyping now. So we initially were just classifying it as adenosquamous, and now we know that adeno is a group of disease and it's not one disease. Why it is important? Because we have mutation-specific treatments available. And if there is an insufficient tissue to allow all the testing, that is EGFR, KRAS, ALK, ROS, BRAF, NTRK123, MET exon skipping, RET, you must repeat a biopsy. And if you are unable to do that, you should do a plasma testing or for these markers, because if you don't do it, then it will be considered as no driver mutation, and you may not be able to give a patient the right treatment. Next slide. EGFR mutations. Next slide. EGFR mutations are the most common identified mutations in adenocarcinoma lung. In Asians, this ratio is 30 to 40% compared to Caucasians, which is 10 to 20%. And this is a guideline which was published in 2017, but there are more tests to add to this particular algorithm. So right now we are doing EGFR 1921, and 20 is also being done because after chemotherapy, you have drugs available for 20, amivantamab and Osimertinib. For ALK positive, ROS positive, BRAF positive, NTRK, RET, MET, you have drugs available. You also have to do some futuristic markers like HER2, KRAS, and PDL1, because all of these are going to decide your treatment algorithms. And there are drugs available for most of these, either in first line or second line after chemotherapy failure. So there is a huge change which is happening in lung cancer, and we need to do these markers. Also, it decides like what will be your first line treatment, what will be a second line treatment, and so on. Next slide. So testing methods in lung cancer can be FISH-based, IHC-based, PCR-based, and this is you may have to do in some tests like in ROS or ALK, you may have to reconfirm it by other methods. Next slide. The evolution of biomarkers. In past, empirical therapies were given based on clinico-pathological parameters. Next slide. And now in current scenarios, we are doing NGS for decision making. We either are doing single biomarker by Sanger sequencing, or we are doing multiplex hotspots, or we are doing next generation sequencing. And this all depends on what is feasible and available. And there will be plasma decision-making tools, which will be looking at NGS. The advantage of plasma-based, it is minimally invasive. It overcomes the tumor heterogeneity, but the limitations are sensitivity is just 70 to 80%, but specificity 100%. So a negative result in plasma is non-informative, does not rule out a mutation, and you may have to repeat it or you may have to go for a biopsy. Next slide. EGFR mutations in lung carcinoma. Next slide. The most frequent EGFR-TKI mutation occurs in exon 19 and 21. Next slide. The samples used for EGFR testing are either formalin-fixed paraffin-embedded sections, fresh, frozen, or alcohol-fixed specimens can be used for PCR. You may use cell block, which is formalin. You may use direct smears, which are alcohol. You may use cytology. You may use surgical specimens. Cytology is suitable for PCR, but cell blocks are preferred. The issue is that more the tissue, more than the size of tissue, the tissue purity matters. Because if you have 20% purity of a tissue, then your detection of 10% variant is possible. And to give you a point here, non-acidic decalcification approach should be done for bone biopsies, because if you do an acid decalcification, then it will be difficult for you to do an NGS or molecular testing. Next slide. The factors which determine the test are sample type, whether there is a high or low volume tumor content, is there an expertise available in your lab, and are you going to test only the known mutations, or if the DNA content is low, or are you going for all the available and futuristic markers? So you should weigh all these things. Based on this, you should choose the platform and then decide. Next slide. If you are considering EGFR mutation detection, then IHC and FISH are not recommended. it should be PCR based or NGS based. You should also use sensitive methods which will detect up to less than 10% of cancer cells. Ultra sensitive detection assays will lead to false positive reports. So anything which is like more than 1% frequency of EGR mutation should be detected by the test done. Next slide. Plasma ctDNA assays for detection of highly sensitive and specific. You can use either single gene, you may use a panel of gene, that is targeted gene panels, or you may use a whole genome based on you are looking at. Next slide. ALK rearrangements in non-small cell. Next slide. Next slide. So I think we have different slides here. Yeah, ALK rearrangement. Next slide. Okay, it is basically rearrangements in chromosome 2 causing novel fusion oncogene EML4 ALK, and it is predominantly in adenocarcinomas. It is independently occurring with EGFR or KRAS mutation, and the prevalence is 3% in non-small cell. Next slide. In most of the cases, ALK IHC is 93 to 100% sensitive and specific compared to FISH. FISH has a false positive rate of 0.1%, and IHC is less expensive, and that's why it's more widely used. Next slide. ALK RT-PCR has high sensitivity, but the detection is limited to predefined fusion partners. So there is a risk of false negative. And there is a high failure rate of RNA-based assays in formalin-fixed paraffin-embedded material. Next slide. ROS rearrangements in non-small cell lung cancer. Next slide. This is a receptor tyrosine kinase of insulin receptor family. There is a downstream pathways responsible for cell growth and proliferation. The incidence in India is 1.6 to 2.3%. It is prevalent in adenocarcinomas, and predominantly it is rearrangement mutations. Crizotinib, entrectinib, ceritinib are the drugs which are approved for this particular mutation. Next slide. FISH is relatively straightforward, easier to interpret than ALK. And a big study, which was a large study for crizotinib, actually looked at anchored multiplex PCR with NGS or RT-PCR. Next slide. ROS IHC is a great screening tool, but confirmation with another method is must. Expression of this particular type is also seen in some other oncogenic mutations like ALK, EGFR, KRAS, BRAF. The algorithm for, next slide, the algorithm for genetic testing with ROS1, if you have done a ROS1 IHC and it is positive, you should reconfirm it by FISH. And if you have done a ROS1 FISH and it is positive, you should reconfirm it by IHC. Next slide. PD-L1 overexpression in non-small cell lung cancer. Next slide. Basically, what you are looking at is negative, which is less than 1%, low, which is 1 to 49%, and high, which is more than 50%. The reason of checking PD-L1 is that the drugs you are going to choose based on the availability. So now if you have a PD-L1 which is more than 50%, you would use a PD-L1 inhibitor or PD-1 inhibitor straight. Or you may use a chemotherapy PD-L1, PD-1 combination based on the tumor burden or symptoms of the patient. If it is 1 to 49, you have to use chemotherapy with immunotherapy. Using only immunotherapy in this particular category is not recommended by experts. And if it is negative, you can use a Nivo-IP combination with chemotherapy depending upon tumor burden. And that is what is possible. Now, PD-L1, we know that it is an expression which reduces T cell activation by binding to two important regulatory receptors. Binding to PD1, it delivers an inhibitory signal that reduces cytokine production and T cell proliferation. And binding to CD80 further reduces CD28 co-stimulation of T cells. Now, these tumor cells and tumor infiltrating immune cells express PDL1, which is binding to PD1 on the surface of T cells, inhibiting T cell signaling and blocking anti-tumor immune responses. So if you have antibodies which target PD1, PDL1, preventing PDL1 binding to PD1 and CD80, inducing anti-tumor immune responses. And also one point you must remember here is, don't be in rush to start an anti-PD1 or PDL1 treatment without looking at all the other targets, because sometimes you may have PDL1 expression even in EGFR positive patients. So that treatment may not work. And if you give an immunotherapy prior to your Osimertinib, your immune reactions are going to be higher. It is always better to start a targeted treatment followed by immune therapies. That is what should be the pattern. And because PDL1 reports come much faster, the TAT is very short and the NGS time is more, these are the mistakes people do in their practice. Next slide. PDL classification is based on, like, you have this 4 companion diagnostics: DACO22C3 for pembrolizumab, DACO28-8 for nivolumab, Ventana SP263 for Durva or Nivo, and Ventana SP142 for atezolizumab. This is based on, next slide, the antibodies used in this particular SP263, 22C3, 28-8, and SP142. And there is a different scoring adopted depending upon the antibody used. So you will have to be, the pathologist has to be really used to this kind of things before they report. Next slide. So the consideration of minimal panel, according to me, everything should be done. But if you are going to do minimal panel, then EGFR, ALK, ROS. Secondary panel should be BRAF, MET, RET, HER2, KRAS, NTRK, and PDL1. It can be either a part of your initial panel, or if the EGFR, ALK, ROS is negative, then you can go for the remaining one. If you are doing BRAF, it has to be an IHC, single gene assay, PCR, or NGS. If it is RET, then it can be FISH, IHC, RT-PCR. NGS by RNA is the most sensitive in this particular pattern. HER2 you can do by IHC, FISH, NGS, or PCR. KRAS you can do by PCR based or NGS. MET you can do by IHC, FISH, DNA, RNA. RNA NGS is sensitive in this particular pattern. NTRK, RNA NGS is most sensitive. You have to confirm it by IHC. And IHC we know is an easy and fast way to do an NTRK. Next slide. So you may do a single gene reflex, or you may do a multiple gene testing by NGS. Next slide. TAT is the most important thing, that is the test turnaround time. Next slide. Histology based TAT should be 1 week, maximum 2 weeks. PCR based TAT should be 2 weeks and not more than that. NGS can give us screening of several genes at a time. Next slide. So reducing TAT, you should send the sample in-house if there is a possibility. If you are sending it to outside lab, then within 3 days. Multidisciplinary meetings should help each other understand the problems, like the pathologist, the oncologist, everybody should be together. The sample should contain at least 10% tumor content should be there. And you should opt for a lab or a platform which gives you result within 2 weeks. Next slide. So to conclude, I would say that because highly effective targeted therapies and lack of efficacy of immunotherapy in these mutations, you should always test for EGFR, ALK, ROS1, BRAF, NTRK, MET, exon, skipping RET, PDL1 at the diagnosis, and then only start your treatment. 50% of patients will have driver mutation, which are targetable by available agents. Biomarker testing should be done. Generally, a broad testing with NGS is required. And also the emerging biomarkers should be tested. Multidisciplinary meetings should be done to understand the problems. Samples should contain at least 10% to prevent delay in processing. Adjuvant osimertinib has prolonged DFS in EGFR positive non-small cell lung cancer according to the ADURA trial, and it should be given for 3 years or up to recurrence or intolerable toxicity. This is generally given after chemotherapy. Adjuvant atezolizumab has been approved after giving chemotherapy in stage 2 and 3 lung cancers, and it is also given for 1 year. Neoadjuvant immunotherapy, if you have used nivolumab for 3 cycles along with chemotherapy, you should not use adjuvant immunotherapy. PD-L1 is important in decision, but you should not be tempted to start PD-1, PD-L1 blockers without having your complete NGS report and looking at all the actionable mutations. Thank you.
Thank you so much, sir. Moving on, I would like to invite our next speaker, Dr. Poonam Patil, medical oncologist from Bangalore. Over to you, ma'am.
Thank you very much. May I have my set of slides?
Just a second, ma'am.
A very good evening to you all. It's great to meet you all here. I thank AstraZeneca for giving me this opportunity. So my talk today is on real-world evidence of use of osimertinib as standard of care in the management of EGFR mutated non-small cell lung cancers. We had a very good talk by Dr. Minish Jain about EGFR mutations, how to test them. Now, what do we do after we know that the patient has got EGFR mutation? Next slide, please. So in patients with EGFR mutations, the progression-free survival improves after treatment with EGFR-TKIs compared with that of cytotoxic chemotherapy. Osimertinib, which is an irreversible third-generation EGFR-TKI, demonstrated a meaningful improvement in PFS in the phase 3 randomized FLORA trial, and the overall survival also was benefited with 38.6 months versus 31.8 months. And it made osimertinib the best treatment option for patients with untreated advanced non-small cell lung cancers carrying an EGFR mutation. Next slide, please. So this is a bit about the FLORA trial. Next slide, please. So FLORA was a double-blind study design which included patients with locally advanced or metastatic non-small cell lung cancers with a good performance status patients, and the patients had to have exon 19 deletion or exon 21 mutation, that is L858R mutation. They should not have had received any prior systemic chemotherapy, and stable CNS metastases were allowed. They were randomized in 1:1 fashion to receive either osimertinib or a comparator EGFR-TKI. And overall survival was a key secondary point. Next slide, please. The baseline characteristics of both the groups were quite matched. Next slide. So look at the progression-free survival in the primary analysis. You look at the separation of the curves. The orange was denoting osimertinib and the green was the comparator EGFR-TKI. Even after 24 months, the lines remained separated for long, and the hazard ratios, almost all subgroups, not almost, in fact, all subgroups benefited with osimertinib. Next slide, please. In the final analysis, the overall survival was 38.6 months with osimertinib, and the comparator arm had 31.8 months. Next slide, please. So to conclude, FLORA showed a statistically significant and clinically meaningful improvement in overall survival with osimertinib, and the median OS for patients in the osimertinib arm was extended by 6.8 months, what we just saw. And osimertinib is the first EGFR-TKI monotherapy to show a statistically significant overall survival benefit versus another EGFR-TKI. And after 3 years, 28% of the patients in the osimertinib arm and 9% of patients in the comparator arm remained on first-line study treatment. So osimertinib presented a favorable and consistent toxicity profile despite prolonged exposure, and this trial reinforces osimertinib as the standard of care for first-line treatment of patients with EGFR mutated advanced non-small cell lung cancer. Next slide, please. So as per the NCCN guidelines, this is of 2021, but in 2022, the picture is no different. Osimertinib remains the preferred first-line therapy in EGFR mutation discovered prior to first-line systemic therapy, where we can start on osimertinib upfront. And if we have started chemotherapy upfront and we discovered that the patient had EGFR mutation, then after the completion of planned systemic chemotherapy, we change over to osimertinib as a maintenance therapy. Next slide, please. Yeah, next slide. Next slide. So we come to some real world evidence of osimertinib. We all know that clinical trials would include the best possible scenario, a very closely monitored subgroup of patients, and real world scenario is very, very different. So I'm going to discuss about 3 studies: the FLOWER study, OSIFACT study, and Mykonos study. Next slide, please. So this was about FLOWER study, which is first-line osimertinib in patients with EGFR mutant advanced non-small cell lung cancer. Next slide. So this is about osimertinib, which again reiterates that in FLORA study, we have seen the benefit of osimertinib. And the estimate is that only 2 to 4% of patients with such kind of cancer receive treatment within randomized clinical trials, thus raising the issue of the representativeness of the sample. And here, real-world data have become useful tools to assess unique insights in routine oncology practice in the post-marketing setting. So these are all post-marketing studies. Next slide. So the key features, the median age was 68 years, 38 patients, that is 30.2% patients had brain metastasis, and the patients were, most of them were stage 4A or stage 4B. Next slide, please. Since it was not a randomized study, the age and the inclusion and exclusion criteria were the following: that age more than 18 years, histologically confirmed diagnosis of non-small cell lung cancer, presence of EGFR mutation in exon 18 to 21. So all mutations were included, unlike FLORA, which had only exon 19 and exon 21 mutation. And the patients with locally advanced recurrent disease or metastatic disease, all were included, and they were eligible to receive first-line treatment with the 3rd generation EGFR-TKI osimertinib. And patients who had received the drug osimertinib in clinical trial scenario were excluded. Next slide, please. So here there was one variable that was under exploration, which was time to disease, time to change of treatment. That is time to treatment discontinuation, which was measured from the osimertinib start to discontinuation for any cause. That was the TTD. It was a novel exploration endpoint, and it was to see what was the rate of treatment-related adverse events, rate of dose reduction, temporary or definitive treatment interruption due to AEs. The secondary endpoints were median overall survival, median progression-free survival, overall response rates, and disease control rates. Next slide, please. Next slide. So patients with poor performance score, comorbidities, rare EGFR mutations, and active brain metastasis were all included, which is what we see in the real world. And these patients were actually excluded in FLORA. Outcomes were similar to published data, thus adding consistency to osimertinib efficacy. There was no difference in progression-free survival, time to treatment discontinuation, and overall survival noted in elderly patients, patients with comorbidities and less common EGFR mutations, what we would say as probably a poor tolerance subgroup. Next slide, please. So these are the graphs that are going to show us the median time to treatment discontinuation in graph A, which was almost 25.3 months. The graph C shows median time to treatment discontinuation in patients with or without symptoms at diagnosis. So if the patient did not have much symptoms, which is the green line in the graph C, they had obviously a longer time to treatment discontinuation, whereas patients who were symptomatic, probably the disease biology was such that the treatment was discontinued earlier. In graph E, it is time to treatment discontinuation in patients with less than 3 or more than 3 or at least more than 3 metastatic sites. So obviously patients who had less than 3 metastatic sites, which was denoted with the green color, that is favorable compared to more than 3 metastatic sites. Next slide, please. So next slide. So time to treatment discontinuation appears to be a more suitable endpoint to evaluate treatment outcomes in pragmatic real-world trials. And TTD was longer than the post-progression outcome analysis of FLORA trial, probably due to study population unfit for further therapy. And a different therapy was used for oligoprogressive disease in the trial. Whereas in real world, if it is an oligoprogressive disease, supposing there is an isolated metastasis in the bone, we would try to radiate that bone lesion and continue osimertinib. So that is why in real world scenario, TTD is sometimes longer than what we see in the best of clinical trials. So better TTD was associated with fewer than 3 progressing sites and isolated progression compared with oligo or systemic progression. Next slide, please. So poor treatment outcome for patients with brain metastasis, presence of symptoms, and at least 3 metastatic sites at diagnosis suggested that tumor load is a negative prognostic factor. So again, these are the univariate analysis and multivariate analysis for progression-free survival, overall survival, and time to treatment discontinuation. Next slide. So again, this highlights the symptoms at diagnosis, whether they were present or absent. The time to treatment discontinuation is early if the patient is having symptoms, and so is the overall survival, and so is the progression-free survival. Next slide, please. This is regarding the significance of number of metastatic sites and brain metastasis. Again, presence of brain metastasis and number of metastatic sites, both are negative prognostic factors. Next slide, please. So the primary assessment, which was the efficacy. Next slide. After median follow-up of 12.3 months, the median progression-free survival was 18.9 months. And the median overall survival was not reached at the time of data cutoff. Most 73% of the patients had partial response, 23% had stable disease, and only 4% had progressive disease. Next slide, please. The primary efficacy as per the different subgroups, as we discussed earlier, the median progression-free survival in patients with or without brain metastasis at diagnosis. Again, patients with brain metastasis did not do as well as patients without brain metastasis. And the progression-free survival in no brain metastasis was not yet reached. Median progression-free survival in patients with and without symptoms at diagnosis. Patients without symptoms continued to do well, and the median survival, progression-free survival was not reached in that subgroup. Next slide, please. The efficacy, this we spoke about it. The median progression-free survival was 18.9 months. I think this slide is duplicated. Next slide, yeah. So this is what we saw in the graph. Longer PFS was noticed in the absence of brain metastasis, and prolonged PFS and longer OS was also noticed in patients without symptoms at diagnosis. And TTD of 9 months or higher was significantly associated with better overall survival. Next slide, please. So essential element of evidence-based medicine, and this could help clinicians in decision-making. And amongst patients experiencing a progressive disease, which was 44 in number, 21 cases underwent a rebiopsy, and tissue rebiopsy was seen in 66.7%, and a liquid biopsy was seen in 28.6% of patients. And molecular analysis was performed in 61.9% patients. The druggable resistance mechanisms include the following: that was MET amplification and EGFR amplification, and HER2 amplification. Next slide, please. Next slide. This was about the adverse events. Diarrhea was a common adverse event seen with osimertinib, as we do see in clinical practice as well. Rash, dry skin, and paronychia. Most of them were grade 1, grade 2, and they were very easily manageable. Next slide, please. Venous thromboembolism was also seen, and that was seen in 9.5% of patients, and 7.59% of patients had grade 3 or grade 4 venous thromboembolism. Next slide, please. Next slide. So in the real world, the ASTRA study also showed that grade 3 pulmonary embolism accounted for 2% of pre-treated patients receiving osimertinib. Next slide. So no differences in rates of VT was reported according to age, performance status, comorbidity, and tumor loads. Next slide. So this is what was seen as per the age, the Charlson comorbidity index, number of metastatic sites, and the performance score. So there was no difference in the rates of vascular thromboembolism. Next slide, please. Next slide, please. Yeah. So this is what it shows, that there was no difference. Whatever comorbidity index, whatever age, whatever number of metastatic sites, or the performance score. Next slide, please. Next slide. So osimertinib confirmed its efficacy and safety in the real world scenario. Next slide, please. This is about the OSIFACT study. Osimertinib as first-line treatment for advanced EGFR mutation positive non-small cell lung cancer in real-world setting. Next slide, please. So this is about osimertinib, which we have all just now discussed about. The current study investigated the differences in efficacy with patient background and the safety of first-line osimertinib treatment in real-world scenario. Next slide, please. So this study included patients with advanced EGFR mutation positive NSCLC with osimertinib as initial treatment, and excluded patients who had concurrently used other anti-cancer agents or even radiation therapy. It excluded patients who had undergone adjuvant chemotherapy, or also who had received osimertinib as second-line treatment. Next slide, please. The baseline characteristics. So most of the patients were between 65 to 78 years of age, and the ECOG performance score was 52. Females were more here compared to males. Again, smokers were less. They were only 38.8% versus never smokers who were 61.2%. Histology, it was adenocarcinoma in 98.3%, squamous cell carcinoma in 0.7%, and non-small cell carcinoma of histology 0.9%. And they all were EGFR mutated, and exon 19 deletion was most common. Next slide, please. Again, this is the distribution of PD-L1 status, brain metastasis, leptomeningeal metastasis, pleural effusion or ascites, pericardial fluid, liver metastasis, interstitial lung disease, target lesions, present, absent. Next slide, please. Next slide, please. The primary endpoint was progression-free survival. Secondary endpoint was time to treatment failure, response rate, safety, and post-treatment. Objective response rate, disease control rate. Next slide, please. Next slide, please. So progression-free survival events occurred in 182 of the 538 patients, and the median progression-free survival was 20.5 months. Next slide, please. So this is what shows the progression-free survival of 20.5 months. Next slide, please. Next slide. Other parameters which were significantly associated with progression-free survival was male gender, malignant diffusions, liver metastasis, and advanced unresectable cases. So all these patients did not do well. The progression-free survival was less than this. Next slide. With respect to PD-L1 expression, the median progression-free survival was not reached in patients with the TPS score of less than 1%, 14.7% with the TPS score of less than 49%, and 11.1 months for those with the TPS score of 50%. When the TPS score was not known, that was unknown, the progression-free survival was not reached in that subgroup, but it was a very small subgroup. Next slide. The primary endpoints, this is what we just discussed about the distribution of these patients. Next slide. So as I discussed, that patients who were males had liver metastasis, malignant diffusions, who had advanced stage, they didn't do as well. And if PD-L1 was 49% or less, they did better compared to higher TPS score of PD-L1. Next slide, please. Treatment discontinuation profile. This is what we generally see in our practice as well. The reasons for treatment discontinuation could be disease progression, pneumonitis, or other adverse events. Next slide, please. So disease progression was 44.3%, adverse event pneumonitis was 25%, and 16% had other adverse events as detailed. Next slide, please. So these were the adverse events. Pneumonitis was the most common. Hematological toxicities and non-hematological toxicities were not as much. QT interval prolongation was 4.1%. And heart failure or reduced ejection fraction, 1.5%. Next slide, please. And pneumonitis was maximum 12.8%, and all AEs leading to treatment discontinuation was 16.9%. Next slide, please. And next slide. So to conclude, the overall response rate was 76.2%, disease control rate was 94.1%, and progression-free survival is better with osimertinib than with conventional EGFR-TKIs, regardless of PD-L1 expression. And the practice of usage of osimertinib in real-world practice was favorable for the progression-free survival, and the discontinuation rate due to AEs, especially pneumonitis, requires further investigation and how to prevent it and how to treat it better. Next slide, please. This is the last study, that was Mykonos study. And this was patients with EGFR mutated locally advanced or metastatic non-small cell lung cancer with first-line osimertinib. Next slide, please. We have spoken about the osimertinib, but here there were two other endpoints, which were RWTT-ND, which was real-world time to treatment discontinuation and death. And this is something that was new in this study. Next slide, please. So this was the study design, that patients with more than 18 years of age with advanced non-small cell lung cancer, EGFR mutation, which was documented, and they were all initiated on first-line osimertinib. Next slide. So again, the patient flow. Next slide. So this is the methodology and statistical analysis. I spoke about the RWTT-NTD, which was real-world time to treatment discontinuation, and ND was actually, NTD was next treatment or death. Next slide. The socio-demographic characteristics, age median was 70 years. Most of the patients were 18 to 64 years of age or 65 to 74 years of age. They also had patients more than 75 years of age. Again, most patients were females, and whites were more in this study. Next slide. Community-based treatment was again more common here. This is the distribution of the clinical features. Next slide. All were EGFR mutation positive, and this was the distribution of the common mutations and uncommon mutations. Next slide. The treatment sequencing, all had received first-line osimertinib, and 103 patients received second-line treatment. 101 patients died while on first-line treatment. 26 patients discontinued first-line treatment, and 318 patients remained on first-line therapy or were lost to follow-up. Next slide, please. So the real-world time to next treatment or death was, the median follow-up was 9.6 months, and this time was 17.9 months. And out of the 204 events, 18.4% died and 18.8% switched to second-line therapy. Next slide, please. In the multivariate analysis, the following variables were significantly associated with this time period. That was stage at initial diagnosis. If it was advanced, the patients didn't do well. Smoking status, again, poor performance status. Charlson's comorbidity index more than 3, poor prognostic feature, EGFR mutation type, in which 19 and 21 did better. Number of metastatic sites more than 4 did not do well. Next slide, please. The median RWTTD was 17.2 months. Next slide, please. And in the multivariate analysis, the similar variables were significantly associated with the real-world time to disease progression or time to treatment discontinuation. That was a high comorbidity index, poor performance score, EGFR mutation type, number of metastatic sites, and evidence of liver metastasis, all as high-risk features. Next slide, please. So this study provided real-world insights into the use of first-line osimertinib in patients with advanced EGFR non-small cell, EGFR mutated non-small cell lung cancers, based on the first data cut analysis of the US subpopulation. And the interim results support the efficacy of osimertinib in this real-world population, and longer-term outcomes will be evaluated in the final analysis. Next slide, please. So I come to the end of the presentation. Thank you all very much.
Thank you so much, ma'am. Moving on, I would like to invite our international speaker, Dr. Herbert Loong, clinical oncologist from Hong Kong. This session is sponsored by AstraZeneca. Over to you, sir.
Thank you very much. Let me just pull up my slides first. Okay, I presume everybody can see my slides. Thank you very much for the kind invitation. I'd like to also thank AstraZeneca for arranging today's webinar. And I actually really enjoyed both Dr. Jain as well as Dr. Patil's talk, looking at the molecular diagnostics as well as the real-world evidence of the use of osimertinib in the advanced disease setting. And certainly, I think we have now more solid data on the use of osimertinib in the adjuvant setting. So I think in the next 30 minutes or so, I will like to go through some of the data that preceded the ADAURA trial, as well as taking a deeper dive into the ADAURA trial and how this practically may change the way we treat patients in the earlier stage setting. And these are my disclosures. So I think to begin with, and just to really follow on from Dr. Patil's talk, we are quite certain that in the treatment of advanced non-small cell lung cancer, things have really significantly changed over the past 2 decades or so. It was not long ago that in the year 2003, there was this one paper, the seminal paper published by Professor Joan Schiller and colleagues looking at the platinum-based doublet chemotherapy for patients with advanced non-small cell lung cancer in the first-line setting. And you would recall that the overall survival or time to treatment progression really didn't matter, regardless of which type of platinum-based doublet you use, be it cisplatin or carboplatin, be it paclitaxel or gemcitabine. And in general, we were dealing with a disease which pretty much was a death sentence, where the median overall survival was only 7 to 8 months. The median time to treatment progression was 3.5 months. And remember that these are treatment naive patients. Now, of course, things have moved on quite quickly in the last 2 decades, and certainly non-small cell lung cancer in the year 2020 and beyond. You would certainly recall that, as also Dr. Patil has mentioned, in the FLORA trial, using the use of first-line Osimertinib in patients with advanced metastatic non-small cell lung cancer harboring a actionable EGFR mutation, we're talking about an overall survival of about 38.6 months. And even in the ALK space, which in actual fact, patients do generally survive even longer, even with a not so good ALK inhibitor such as crizotinib in the Profile 1014 trial, we're talking a median overall survival of about 60 months. So that's a far cry from what we were still treating just about 1 to 2 decades ago. Now, we've spent a lot of time focusing on advanced disease, and I think my talk really is to talk about the improvements in survival in selected patients in the adjuvant setting. And certainly all these improvements don't come easy, and they were really established through evidence as well as clinical trials and clinical practice in the advanced setting. And with our experience, we're now moving forward and covering the adjuvant space. And adjuvant itself is a big population, because if we're talking about adjuvant non-small cell lung cancer patients, patients who are resectable with resectable disease at diagnosis accounts for about 30% of our population. Certainly when it comes to the treatment of these patients, surgery remains the mainstay of treatment, and it is of curative intent in the primary treatment in patients with resectable disease. And prior to us having established evidence with the use of TKIs in a selected population such as EGFR, the real armamentarium for patients in terms of adjuvant setting is really cisplatin-based chemotherapy. And this is, of course, indicated in patients with stage 2 to 3A non-small cell lung cancer, as well as selected patients with stage 1B disease. Now, I think the biggest problem, of course, is even though we are treating these patients with curative intent, either in the early stage or the regional locally advanced disease, be it stage 2 or stage 3, there is actually quite a significantly high chance of recurrence or death. And certainly a stage 1B lung cancer in terms of recurrence risk is higher than, for example, a stage 1B breast cancer. So I think there's a lot of space for us to improve our treatment outcomes. Now, just to remind ourselves of what the at least solid data is in terms of the use of adjuvant platinum-based doublet chemotherapy in patients with early stage non-small cell lung cancer, and essentially based on the individual trials as well as the subsequent meta-analyses, there is about a 5% survival benefit at 5 years in patients with resectable stage 2 or stage 3 non-small cell lung cancer. And you would recall that this is the LACE pooled meta-analysis of 5 randomized adjuvant cisplatin trials performed since 1995. Granted that these are older trials, and certainly we're talking about trials from a decade or a decade and a half ago, but we're really talking about a 5-year survival benefit of about 5.4%. And certainly in other meta-analyses, we're talking about a very similar number of about 4%. Now, specifically looking at EGFR though, and certainly this was discovered a bit later on, and certainly we have now established EGFR tyrosine kinase inhibitors for the advanced setting. We have first generation, second generation, as well as third generation. It's important for us to now think about whether or not these patients, when they present in the early stage setting, is in a position to receive such targeted treatments. Now, approximately 1/3 of patients presenting with early stage non-small cell lung cancer have tumors that harbor EGFR mutations. The distribution is pretty much similar, regardless of what stage the patients present. But of course, we are also aware of the fact that in Asia, we do have a higher mutation prevalence of EGFR compared with our American or European counterparts. So there, therefore, is a big space for us to improve treatment outcomes. Now, this is a relatively busy table looking at some of the key adjuvant EGFR tyrosine kinase inhibitor trials in early stage non-small cell lung cancer. These are the selected trials which used first generation EGFR-TKIs, which included the use of erlotinib as well as gefitinib. The first trial is the SELECT trial, which essentially is a single arm phase 2 clinical trial using erlotinib. And this included patients from stage 1 to stage 3A. There's also the RADIANT trial, which actually on its original design did not actually specifically select EGFR mutated patients, but it was really patients who have essentially early stage non-small cell lung cancer. And this was a global trial, however, a phase 3 trial. There's also the EVAN trial, as well as the adjuvant CTONG1104 trial coming up from mainland China. I will talk about each of the trials briefly in the next couple of slides, but just really to impress upon you that the way we have been tackling the adjuvant space for EGFR positive disease included trying to compare it against chemotherapy, as well as also possibly following on from chemotherapy. And each of these trials, although we are actually looking at a very similar population, these are early stage EGFR positive disease patients, the approach is somewhat slightly different. So I think it's quite difficult for us to put all these together into one big meta-analysis to try to establish its evidence. Now, looking at these specific trials in a little more detail, the SELECT trial, as I mentioned, is a single-arm phase 2 clinical trial with the use of adjuvant erlotinib in patients with stage 1A to 3A EGFR mutated non-small cell lung cancer following complete resection. In these patients who were recruited into the clinical trial, they actually were allowed to have a completion of their adjuvant chemotherapy as well as radiation therapy. This was a single arm phase 2 trial where the primary endpoint was a 2-year disease-free survival. Now, the results was positive, but of course, in terms of establishing evidence on the use of adjuvant treatment, one of the biggest caveats is the fact that this was a single arm open label trial and their comparison was with historical control. And certainly, I think in the adjuvant space, especially in such a large population, I think it's important for us to have more contemporary data to establish such evidence. Now, the RADIANT trial is a randomized phase 3 trial. It's placebo-controlled in the use of adjuvant erlotinib versus placebo in patients with stage 1B to 3A non-small cell lung cancer. In this particular trial, again, adjuvant chemotherapy was permitted, and it was a randomization on a 2-to-1 fashion to either erlotinib versus placebo, but the primary endpoint being disease-free survival. The study population was very large. The total number of patients recruited was above 950 patients. But the problem with this particular trial was it came with a recruitment of all comers in the sense that it allowed patients with EGFR immunohistochemistry positive or amplification by FISH being positive, but there was no specific recruitment in terms of numbers looking at patients with EGFR mutations. Now, retrospectively, they were able to tease out the about 100 odd patients with EGFR mutations within the group, but this was never controlled in terms of its recruitment. Granted, when they started this trial, in actual fact, I don't think they actually realized the importance of EGFR mutation as opposed to IHC or amplification. In any case, in the EGFR mutated subgroup, what they found was the disease-free survival was shown to be statistically improved in patients who were recruited into the erlotinib arm versus placebo, but there was no overall survival benefit. Now, a bit more in the contemporary side, this would be the CTONG1104 trial coming from mainland China, which included patients with stage 2 to 3A, which was N1 or N2 disease with EGFR positive non-small cell lung cancer. These patients must have had complete resection, but in this particular trial, they were not allowed to have adjuvant chemotherapy. And the comparison was not placebo, but it was actually trying to compete against chemotherapy, be it vinorelbine plus cisplatin. And the primary endpoint was disease-free survival. Now, in this particular trial, the median disease-free survival of the gefitinib arm was 28.7 months versus 18 months in the chemotherapy, and this was statistically significant. It was actually better in the N2 subgroup, but in the N1 subgroup of patients, in actual fact, it did not reach statistical significance. More importantly, subsequent updates showed the fact that there was no significant improvement in overall survival in patients who were treated with gefitinib versus chemotherapy. However, the use of gefitinib was much better in terms of quality of life as opposed to chemotherapy. Now, with the CTONG1104 trial, this was actually subsequently updated. Initially, it was presented as a paper in Lancet Oncology in 2018. And then Professor Yilong Wu then also presented some updated data at the ASCO meeting in 2020. Actually, I'm not going to go into too much detail into what has been updated, but what I do want to bring about was, in actual fact, during the presentation, it was determined that the disease-free survival at 3 years and subsequent the 2-year update at 5 years both showed statistically improved outcome in patients who were treated with gefitinib versus chemotherapy. And this was the Kaplan-Meier curve. But if you look at the Kaplan-Meier curve closely, and this is the red line, which showed 24 months, which was the duration of treatment for patients with gefitinib. After completion of 24 months, only about 60% of patients remained disease-free. So in actual fact, 40% of patients already actually had disease progression before completing the originally prescribed 2 years of gefitinib. So this really is not ideal. There are certainly some questions to ponder then from this trial. Number one, you could see the survival curves tend to converge over time. So then the question is gefitinib as a first generation EGFR inhibitor just not potent enough in terms of preventing recurrence? I think the other question is it really fair for us to be pitching EGFR-TKIs appropriately against chemotherapy as a competitor, when in actual fact, there is potential add-on effects of, say, using chemotherapy first, then followed by EGFR-TKIs. Now, the CTONG trial, as well as some of the other trials, actually gave us a bit more insight, though, into the spectrum of recurrences in patients who do have EGFR positive disease. And in the CTONG trial, as well as some of the other trials, what we found is the fact that in patients who had EGFR positive disease, there does tend to be a high propensity for having CNS metastases when patients do recur after initial resection. And in this particular distribution of patients who were either treated with gefitinib in the treatment arm of the CTONG trial or in the chemotherapy arm, what you found is the fact that there were actually more patients benefiting with gefitinib, as in there were less patients who have developed recurrence when they were treated with gefitinib versus chemo. But there were also numerically more patients as a first recurrence being in the CNS. Now, in this particular analysis, though, you have to note the fact that the timing of these recurrences were not registered within this graph. So I think you could also argue that in patients who were treated with chemotherapy, because there was not such a good systemic control, when they did recur, they would recur systemically. Whereas for patients who are treated with, say, EGFR-TKIs, there's actually a longer duration until they recur. So therefore, they were able to actually develop a CNS metastases, which tends to come a little later. But looking at all the different trials which have looked at the use of adjuvant EGFR-TKIs, what again, as I've pointed out earlier, is the fact that the incidence of CNS recurrence tends to be quite high. And in terms of trying to treat patients in the adjuvant setting, we really should make sure that our treatment strategies do include some sort of CNS coverage in terms of prevention of brain metastases. Now, going to the ADAURA trial, and certainly this is the main crux of our discussion today, is really to see whether or not a third generation EGFR tyrosine kinase inhibitor can potentially change the way we may want to approach these patients. So the ADAURA trial is the randomized phase 3 trial looking at patients with stage 1B, 2, or 3A non-small cell lung cancer with or without the use of adjuvant chemotherapy, harboring either an exon 19 deletion or an exon 21 L858R mutation non-small cell lung cancer. And in the inclusion criteria include our typical patients who had to be adults, good performance status, confirmed the fact that it is a primary non-squamous non-small cell lung cancer, and it allowed for the use of chemotherapy. And certainly for the patients who you would think routinely will be given chemotherapy, they would have had to complete chemotherapy first before study entry. Patients was actually stratified by either stage, the EGFR mutation status, as well as race, being Asian versus non-Asian, and randomized to a 1-to-1 fashion between osimertinib as well as placebo. and the osimertinib was planned to be treated for a duration of 3 years. The treatment continues until the presence of either disease recurrence or treatment has been completed or the discontinuation criterion has been met. And there were some regular follow-ups. The primary endpoint of this particular trial is to look at disease-free survival by investigator assessment, and as well as secondary endpoint looking at the disease-free survival in the overall population, as well as some either pre-specified exploratory analyses as well. Now, I think you'll also be aware of the fact that with this particular trial, it was actually unblinded early because of efficacy that was actually noted by the Independent Data Monitoring Committee. And in actual fact, the data was subsequently announced at international conferences not too long ago. Now, looking at the baseline characteristics of the patients who were recruited into the trial, overall, in actual fact, between the osimertinib arm as well as the placebo arm, it was quite well balanced. Specifically looking at patients who have had or not had prior adjuvant chemotherapy, about 60% of the patients in the osimertinib arm, as well as in the placebo arm, have had prior chemotherapy. Now, going back to the unblinding of the study, and certainly this is one of the issues that's always being debated as to whether or not we will ever get overall survival data for these patients. But a bit of background is the fact that the unplanned efficacy analysis was requested by the Independent Data Monitoring Committee. Because of the fact that the primary endpoint, which was actually disease-free survival in the stage 2 as well as the stage 3 patients, was clinically and statistically significant, resulting in the recommendation of unblinding the results early. This was actually not an interim efficacy analysis, but in actual fact, this is an unblinding was requested because of this positive signal. Now, I think it's important, though, also to note the fact that when this trial was unblinded, the unblinding was carried out at the sponsor level, but in actual fact, in the patient as well as the physician level, when patients are actually being treated in the clinical trial, they were not aware of which particular arm they've been recruited in. And in actual fact, they, in the local sort of level or patient level, are only unblinded as our standard procedures, where if there's evidence of, say, disease recurrence, or if there's a medical emergency, then therefore they are unblinded in their treatments. Now, this is essentially the results, and these are the two most important graphs in the New England Journal of Medicine paper, as well as in the presentation that was made at ASCO. And the left is the primary endpoint, which is the disease-free survival in patients with stage 2 or stage 3A EGFR positive non-small cell lung cancer. And you could clearly see the fact that in the there's superiority of osimertinib versus placebo, where the hazard ratio is 0.17. If you look at the probability of disease-free survival at 12 months, 24 months, and at 36 months, again, clearly superior, and certainly there's a large separation of the survival curves. Now, of course, CNS protection is something that we find being very important in this group of patients. And again, you can see the fact that osimertinib versus placebo, very strong CNS protection. And actually at 36 months, only a very small number of patients actually had any CNS progression events. Now, the secondary endpoint is for all comers into the trial. So not only stage 2 and stage 3A, but also included stage 1B patients. What you can see again is the clear separation of the survival curves between osimertinib versus placebo. The hazard ratio is 0.2. And in actual fact, the median disease-free survival in patients who were treated with osimertinib was not reached, nor in actual fact was the lower boundary of the 95% confidence interval. Looking at the different subgroups within the clinical trial in this forest plot, regardless of sex, age, smoking history, race, stage of disease, or the type of EGFR mutation, but more importantly, whether or not they've actually received prior adjuvant chemotherapy, it does appear that the use of osimertinib is favored as opposed to placebo. And if we break it down by the different stages presentation of the patients, essentially what you can appreciate is that osimertinib is efficacious in all stages within this particular clinical trial, including stage 1B, stage 2, and stage 3A, granted that the magnitude of improvement is more significant in the higher stage disease, and this is to be expected. In stage 1B, the overall hazard ratio is 0.39, which is still quite respectable looking at this individually. Now, adjuvant chemotherapy, again, is always a contention in this clinical trial because there would be some thoughts as to whether or not there is such good efficacy in patients with or without the use of adjuvant chemotherapy. Is it possible for us to omit adjuvant chemotherapy in patients with EGFR positive disease? Now, just looking at the patients who were recruited first, as expected, what you would find is that the patients of higher stage disease, there were actually a larger proportion of patients who have received adjuvant platinum-based chemotherapy. Early stage disease, the majority did not receive adjuvant platinum-based chemotherapy, and the number of patients who received platinum chemotherapy was balanced within the same stage for patients in the Osimertinib arm or the placebo arm. Now, this is actually the analysis looking at whether or not patients have received adjuvant chemo or without adjuvant chemo. So on the Kaplan-Meier curve on the left are essentially all patients, so stage 1B, stage 2, and stage 3A, who have received adjuvant chemotherapy, showing the fact that Osimertinib is superior to placebo, and also in the patients who actually did not receive adjuvant chemotherapy, also showing Osimertinib is more efficacious than placebo. Now, there will always be a question as to why, in actual fact, the survival curves of these patients who did not receive adjuvant chemotherapy seem to do better, and whether or not the adjuvant chemotherapy itself is causing some toxicity. But in actual fact, I think it really has to do with patient selection. And certainly for the patients who never receive adjuvant chemotherapy, it's because they are probably patients who are at a lower stage and therefore lower risk of recurrence. Now, looking again at the individual stages and their survival with adjuvant chemotherapy or without adjuvant chemotherapy, again, without going into too many details, what you can see is, again, a clear separation of the survival curves in stage 2 and stage 3. In stage 1B, there is some separation of the survival curve. Granted, there is this one little crossover here. And looking at it into more detail, what you realize is the fact that there are a number of events that have occurred in patients with stage 1B have been relatively low. And I think the shapes of the survival curve right now really may not necessarily pan out to be the case as we follow up these patients for a longer period of time. So I don't think this crossover is something that we should be concerned about at this particular juncture. Now, I think it's, again, very important to stress the fact that the ADAURA study was not designed to assess the effect of adjuvant chemotherapy, but rather it is to assess the effect of Osimertinib in patients who were either treated with or without adjuvant chemotherapy. Now, going to how the use of adjuvant Osimertinib may change the sites of disease recurrence. This is something that's probably important in terms of planning the patient's subsequent monitoring. Now, I think what we have realized is the fact that, number one, the use of adjuvant Osimertinib has decreased the risk of recurrence in any locations. So patients who were treated with Osimertinib had an 11% risk versus 46% in patients who were treated with placebo. You would also recognize the fact that in all the different areas of where there can be recurrence, in actual fact, again, less in patients who are treated with Osimertinib. And I think most importantly, the biggest magnitude of difference in terms of recurrence location really has to do with the CNS, where 10% of patients treated with placebo had a recurrence, whereas only 1% in the patients treated with Osimertinib. And this is also a graph showing the cumulative risk of developing recurrence either extracranially or intracranially. Essentially, the blue lines are the ones which are treated with Osimertinib versus the yellow ones treated with placebo. The solid line has to do with CNS recurrence, really just hammering home the fact that patients who were treated with Osimertinib really had a very, very low risk of CNS disease recurrence as opposed to being treated with placebo. Now, I think in terms of the side effect profile, I think Dr. Patil has already gone through some of this in the real world data, and certainly the side effect profile in these patients would be very similar to patients who are treated in the metastatic setting. If anything, it would be less than patients in the advanced stage setting, given the fact that generally speaking, I think most of the patients who are treated in the adjuvant setting is of a better performance status, and therefore the risk of having other comorbidities which may contribute to any of these would be less. Now, so I think at the end of the day, what we've realized is the data from the ADAURA study has been very compelling, and therefore, in actual fact, it is now incorporated into the NCCN guideline for us to consider the use of osimertinib in essentially stage 1B, stage 2A, as well as stage 3A patients who were treated with prior adjuvant chemotherapy or not, and if they harbor a actionable EGFR mutation. So in conclusion, the ADAURA trial actually has shown a statistically significant and clinically meaningful improvement in disease-free survival in patients with stage 1B, 2, and 3A EGFR mutated non-small cell lung cancer. This improvement in disease-free survival has been consistent, regardless of whether or not the patients have received prior adjuvant chemotherapy. I think, again, just to stress this point again, the data, however, does not support the omission of chemotherapy in patients who are otherwise suitable or eligible. And adjuvant osimertinib has demonstrated an 82% reduction in the risk of CNS disease versus placebo. The safety profile is well established, and based on the ESMO guideline, or the ESMO magnitude of clinical benefit scale, this has been given an A ranking, therefore really just confirming the importance of its efficacy and essentially the robustness of its data and how it translates to the improvement in survival for our patients. So with this, I would like to end my talk, and I'd be happy to answer any questions, as well as participate in the panel discussion a little later on, where we could discuss a bit more in terms of osimertinib's positioning. So thank you very much.
Thank you so much, sir. Moving on to the panel discussion, I would like to invite our moderator, Dr. Ullas Batra, medical oncologist from New Delhi, and a panelist, Dr. Herbert Loong, clinical oncologist from Hong Kong, Dr. Prabhat Malik, medical oncologist from New Delhi, Dr. Chintan Shah, medical oncologist from Ahmedabad, Dr. Vivek Agrawala, medical oncologist from Kolkata, Dr. Adwaita Gore, medical oncologist from Mumbai, Dr. Indranil Ghosh, medical oncologist from Kolkata, Dr. Kancham Biswas, medical oncologist from Bhubaneswar, Dr. Deepak Kopaka, medical oncologist from Hyderabad, and Dr. Manish Singhal, medical oncologist from Delhi. So please note that Dr. Deepak and Dr. Manish will log in soon. Thank you, sir. Over to you.
Okay, fantastic that was. Dr. Herbert Loong, I must congratulate you for a fantastic talk. And I don't think that you have left any question for us to discuss. I think by and large, everything what I wanted to discuss in the panel discussion has been briefly alluded to and comprehensively answered. But as a moderator, it is my job to plant some seeds of doubt in the panelist mind, and maybe take your expert advice about how to follow the things. So let me start my discussion, and we're already late, and I'm sure it is very late in Hong Kong. What time is it, Dr. Loong?
It's 11:24, so not too bad. It's a long weekend, so we're good.
Okay. That's the same way Tony says, you know, he is very happy. I think Hong Kong is good for the nightlife, I guess. I mean, Tony till 10 o'clock Indian time is absolutely okay. It's 11:45, 12 o'clock, they say, okay, it's getting a bit too much. Okay, so, you know, panel discussion on early stage non-small cell lung cancer. When I got this from the Astra, what I thought was what Astra wants us to discuss is yes to osimertinib in the early setting, in the stage 4 setting, in everywhere actually in the EGFR mutant thing. What we will actually discuss over here, and with permission of Dr. Loong and Professor Prabhat Malik, is to take a balanced view. And we will basically say, because I totally believe that there are two sides to a story, and somewhere in the middle lies the truth. I think not everybody. So let's just discuss the data threadbare right now. So let's start with the discussion on ADAURA, and I'll ask Dr. Ghansham Biswas Dr. Ghanshyam, and you come from Northeast, a very busy and heavy practitioner, as we say in our terminology. Is this issue even clinically relevant? EGFR mutation in adjuvant setting? How many patients do you get who get operated and then have a EGFR mutation? So is that issue really relevant?
First of all, I belong to East, not the Northeast.
Okay. So, see, that is what I'm telling you, no? Yes, Dr. Ghanshyam.
So second is definitely scientifically it is relevant, but in practice, so in a year, I see not even 10 patients who are operable, and out of 10 patients, if I have done an EGFR, so probably or 2 patients who have turned out to be positive. So it's rare because we don't see a patient who undergoes surgery. Otherwise, scientifically, it makes sense for a disease which doesn't have a good outcome. So once there is a jump in the stage.
Okay, so scientifically, yes, and practically and realistically, not much really. I mean, and you didn't even add to the cost of the treatment. Out of the 2 patients out of 10, 100% of them will disappear from your clinic the moment you give them a treatment this costly. Okay, let's go to the Western coast now. Dr. Chintan, relevant?
Yes, sir. I echo Dr. Ghanshyam, sir. So it is scientifically relevant, but clinically and practically not relevant.
Okay, let's go to the heart of the India, Dr. Professor Prabhat Malik. I always forget to answer, quote in the right way. Yes, Professor.
Oh, come on. Yeah, I mean, before ADORA trial, I would say if this panel discussion would have happened, probably we would have all surgeons and maybe hardly one medical oncologist just to say adjuvant chemotherapy. And nobody would have talked about testing EGFR mutation in a resectable lung cancer. But yes, things have changed. This is relevant because you cannot really ignore the magnitude of benefit which you see. So it's worth testing and worth evaluating.
Okay, so Dr. Herbert Loong, I would like to take your opinion. I mean, how many people do you have a lung cancer screening program in your island country? I'm not so sure what is the right status right now. and is it, and how many patients approximately in a year do you get?
Yeah, that's a good question. So to begin with, we don't actually have a lung cancer screening program in place in Hong Kong. So I think one of the biggest contention in sort of answering this question is, are we actually picking up these patients to begin with? So it's only, I think, maybe in the last year or so that we got our pathologist to do a reflex EGFR test, even in resectable patients and not just in the advanced patients, mainly because of the ADORA study findings and now having a position to treat them adjuvantly. So in actual fact, if we count the number of patients in my own institution, for us, we see about 5,000 new cancer patients in our hospital, about 1,500 non-small cell lung cancer patients. In terms of the adjuvant space, EGFR positive, I think we're really talking about maybe about 200 patients each year in the institution. And in actual fact, for us in Hong Kong, the use of adjuvant Osimertinib has some government funding, but this is based on a means tested situation where they would assess your financial situation. If they deem that you have the means to pay for it, then they would not sponsor you. So in Hong Kong, you have to be either very poor or very rich. That's the only way you can actually get good healthcare.
Okay, that's fantastic. That is nice numbers, Prabhat. Very curious to know. So 1,500 lung cancers per year in Chinese Hong Kong University of Hong Kong, and 200 EGFR mutants. That's across all the stages, Dr. Loong, I guess.
That's across all status. That's probably also patients who are being seen initially by us. Of course, we also get referrals from outside centers. So the actual numbers are a bit more than that. But it's a bit difficult for us to predict where these patients will be referred to by the private oncologists.
So Prabhat, your number in names, just a ball, it's got no connection with this panel discussion, but just a ballpark figure.
So annually, we see around 800 to 1,000 lung cancer patients. And our frequency of EGFR mutation is around 25%, which is consistent over the last few years. And talking about the number of resectable lung cancers, so if we see around somewhere between 35 to 40 lung cancer surgeries are done annually.
35 to 40 lung cancer surgeries or lung cancer surgeries?
Resectable lung cancer, I'm saying.
Resectable lung cancers. And then approximately 30% of them will turn out to be EGFR mutant. That's what you're saying.
Yeah.
So approximately around 10 to 20 patients per year is what you are by and large looking at.
Right.
Okay, and that's one of the largest and one of the most premium institutes in the country, actually. And what proportion of your patients would undergo surgery in the early setting, Dr. Loong? If I missed that data.
Oh, I think all the patients who do present to us at an early stage are brought to the MDT, and if they are potentially operable, are
a ballpark figure about how many surgeries for lobectomies, you know?
I think we're talking about 80 lobectomies or sort of wedge resections per year for our early stage non-small cell lung cancer patients.
Okay, fantastic. So by and large, we also get around 750 to 800 lung cancers per year, out of which we usually get some around 50 lobectomies per year. Somehow this has not really changed much in the last 4-5 years. The only thing is the outcomes have become better for people who undergo surgery because they are done by a thoracic surgeon and stuff like that. So, but the number of surgeries haven't really increased. So maybe the screening is one thing which we are missing. Dr. Indranil Ghosh, any idea about TMC Kolkata numbers?
First of all, I am not working at TMC Kolkata. I work at
I see you mixing everything wrong today.
Yeah. Okay, so then, actually, it's very similar to Dr. Ghanshyam because my setting is very similar to his and the region as well. So around 10 lobectomies or lung cancer surgeries per year. Okay,
fantastic. Okay, so let's go to the pre-ADAURA era, and Dr. Loong did show some great curves about that. I'll tell you my comments on that. So Radiant was this study. If you look on the left side, there was no difference, but this was an all-comer study. If you took up the EGFR mutant, it was 46.4 versus 28.5. However, this was subset analysis. This was a single arm trial, phase 2 trial. So that was compared only with the historical controls. This was SELECT, which was a phase 2 trial of adjuvant erlotinib. Again, single arm phase 2 DFS advantage seen. This was a very nice study because it gave info about treatment and relapse. So there were 26 patients who relapsed on erlotinib. When they relapsed, they stopped the treatment. They relapsed again. They were biopsied. Only one of 26 patients, if I remember rightly, was T790M present. Again was treated with erlotinib, and patients is reasonably well on that. So this was one small info about what do we do next with them. This was obviously the adjuvant study which had compared. So the initial studies had compared single arm, and this was gefitinib against nevilbine cisplatin, and a great DFS advantage, but no OS advantage, and that's what everybody is saying. The 3-year DFS advantage was also not significantly different from placebo. There was a high rate of CNS recurrence. Dr. Loong did show 27% versus 24%. So Advait, what were you doing before ADAURA? Professor Prabhat Malik said that, only one medical oncologist, and the comment was only whether you do chemo or not. These were huge numbers. That is, the DFS was very high. Were you giving gefitinib prior to 2020 in the adjuvant setting? Dr. Advait is there? Not there. Dr. Indranil.
Sorry, what was your question?
The question is, prior to ADAURA, whether you were in an EGFR mutant, were you treating them with oral TKIs after chemotherapy?
No, I was not treating them.
And what was the reason you were not treating them?
Reason I was not sure if it at all improved any survival as compared to retreat or treatment with TKI at the time of relapse.
Okay, so let me ask this question to Dr. Rakesh Reddy is there? Okay, people seem to be dropping out. Okay, Prabhat. So this was in 2017. You had this beautiful DFS advantage of 0.61. You were the lung cancer in charge at All India Institute of Medical Science in 2017. What stopped you from giving gefitinib? The OS was not yet there right now.
Yeah, not really. I was confused, but at that time, we were not really convinced. I mean, the difference was not such, it was a significant difference, no doubt. But it was maybe kind of a modest advantage.
The HR of 0.60, Prabhat, we have all been giving immunotherapies in first line because of HR of 0.60.
This is curative. This was curative setting. Yeah, yeah.
So you were waiting for the OS advantage.
Right.
So even with a DFS of 0.60, you were not giving gefitinib, and I'll come to ADAURA in a moment. Dr. Ghanshyam, were you giving gefitinib? You are muted, Dr. Ghanshyam.
So first of all, I was not testing for EGFR. So
you're not testing for EGFR. That was the best thing. Okay. So let me go on to Dr. Herbert Loong. Dr. Herbert, were you giving gefitinib prior to 2020?
No, I think, and very similar to what's been mentioned by other panelists, we were not testing. I think, again, it's a chicken and egg thing because, you know, we have DFS improvement, but there was no OS data. And I think at least back then, you would think that for any adjuvant treatment, you need OS, right? I mean, certainly that was the belief with breast cancer, colorectal cancer, and why not lung cancer? So therefore, we didn't test, and we wouldn't even consider using, say, gefitinib or erlotinib in these patients.
So if I agree, and I'm coming to you, Dr. Vivek, I seem to be missing you in between today. Just because there was no overall survival advantage, even with an HR of 0.60, we were not giving gefitinib. And there is no OS advantage as yet with ADAURA, and I'm come to that whether we'll give osimertinib with the adjuvant setting. So this was the adjuvant trial, clinical trial design. Dr. Vivek, your thoughts about the trial design? Do you think this is a good trial design? Whether we basically, do you think chemotherapy is an essential part? The down one, whether once the patient gets surgery, then you give them option of chemo or TKI. Or after chemotherapy, you put them into, if you're, let's say, if ADAURA had a first generation TKI arm, do you think the difference would have been a bit too much? Did we set the bar a bit too low? Vivek?
Yeah, I think that would have been an interesting analysis if there was a first generation TKI arm too. But I think with the current analysis, we do have a subgroup analysis of patients who were exposed to chemotherapy and patients who were not exposed to chemotherapy. And the benefit is something which is seen in both the arms, whether they had received adjuvant chemo or not. And maximum of the patients had received adjuvant chemo, if I can remember correctly. So I think, if there would have been a first generation TKI, then probably it would have been a much more interesting analysis, and probably much acid test for osimertinib.
So Dr. Herbert, because we're running short of time, I'll ask this question directly to you. Do you think the bar was set a bit too low in ADAURA? Do you think they played very smart?
No, I think the bar is fair. I mean, I think to begin with, the chemotherapy is an important component. I mean, time-tested chemotherapy is the only thing that's had an overall survival advantage. So I think to pitch it against chemotherapy is probably not fair for recruitment of patients either. I mean, you put them into the investigational arm, be it osimertinib or whatever, and you don't give them chemotherapy, you can't really give it back to them when they recur, right? So I think that for design-wise, it's important to have the chemotherapy first in the ones that I indicated. Now, then the question is, do we add a first generation to compete? I guess we can, and it would be more interesting. But on the other hand, I mean, all the first generation trials, at least the larger ones, really only showed DFS and no OS benefit. So I think when ADAURA was actually designed, of course, they were hoping, the primary endpoint was DFS, but they were also hoping that they would get to a secondary endpoint of OS. But it was the magnitude was just so big that I think they decided to cash in the checks.
So I was reading a statement by the FDA people, and they said the magnitude of the benefit of DFS was so high that they had to give a conditional approval for that. I mean, it was 0.61 is okay, 0.5 is okay, but 0.17, 0.12 is a bit too much. So Prabhat, I'll come to you. The duration of adjuvant TKIs, the 3 years. From where did we get the 3 years? All the initial trials had 2 years, and then everything. How did we come to 3 years?
And it's very difficult to say. And what you're looking at ADORA trial is at the point of 2 years, which is the follow-up is maximum is up to 2 years. You're looking at this trial where you're giving a 3-year treatment at 2-year interval.
Yeah.
So, I mean, that may be the reason that you don't have too many recurrences in the Osimertinib arm so far.
Yeah.
I mean, things might turn to the same side where, like the way you saw CTOM, I mean, it may turn to the same fate. That we don't know. And if you ask me how long we should give treatment, probably longer than even 3 years.
So you're
I mean,
going
it's like breast cancer.
adjuvant treatment of 10 years.
Cancer. Yeah. So who knows? I mean, the optimum duration, nobody knows.
Okay. Okay. So I found out some studies about why 2 years was selected from for the Gefitinib and the Erlotinib, and there what was said that the median DFS was 12.2 for N2 disease and 1921 for N1 disease. That is why 2 years was taken. But why 3 years? Whether they extrapolated the Imatinib data from GIST, we don't know actually, and whether it was arbitrary, whether they just wanted to rein in cash, as Dr. Loong said, we don't know.
Yeah, I agree, Ullas. I mean, that the reason may be because most of the recurrences happen in first 2 years. But that's true with adjuvant chemotherapy. Yeah. What's happening in adjuvant TKI is probably we are delaying the recurrences. And the moment you stop the TKI, the recurrences may still happen. Okay.
So, Dr. Ghanshyam, the results, impressive or not impressive or super impressive?
Super impressive.
Super impressive. Dr. Chintan, impressive,
Yes,
super impressive? Super duper impressive. And since we all want to go for a dinner and Dr. Loong wants to go for sleep. Okay, let me just then come to Dr. Indranil Ghosh. Dr. Indranil Ghosh, the DFS versus the OS dilemma. I mean, initially we were all not giving Gefitinib because there was only a DFS advantage. There is no OS advantage. Has the bar, so what are the advantages of DFS and OS basically as far as you are concerned? Dr. Indranil.
Yeah, OS is the ideal in this scenario for me, but to get a OS difference, it will take, if it was taken as the primary endpoint, it would take a much longer time and probably much higher number of patients to recruit. So as a starting point, the DFS is a good one, but maybe for 1B, it's a bit dicey. But okay, for 2 and 3A, we can safely assume that this DFS will be converted to an OS benefit.
You're happy with the DFS, right?
Yeah.
Okay. Chintan?
Yes,
happy
sir.
with the DFS versus the OS debate?
Yeah, especially for the adjuvant therapy, I think DFS is also important and would definitely consider DFS as one of the endpoints, especially when you are thinking of adjuvant therapy.
Okay, Dr. Ghanshyam, did they lower the bar? I mean, we have a picture of Donald Trump lowering the presidential bar in US. Did we just lower the bar if we have not taken, with Gefitinib, we were not willing to accept. For Osimertinib, the magnitude of benefit is high, but who knows? Did we lower the bar or is it okay?
I think we have lowered the bar.
You have lowered the bar. You are a purist. Okay.
Yeah. Just wanted to say something, Dr. Ullas.
Yes.
Yeah. So one of the important secondary points that the trial showed was the number of CNS recurrences. What we can understand that if CNS recurrence occurs, then the OS is really bad, and the quality of life is bad, and the patients are doomed. And the number of CNS recurrences are very, very low with the Osimertinib arm as compared to the non. I think the difference is almost close to 30-35%. Yep. So that is one of the major sort of initial benefits that we are seeing, even though the OS data is not there. But that is something that comes out as a very, very contrasting thing. And of course, when you look at the huge DFS benefit with the huge HR. So these are very, very suggestive.
True that. So I mean, a huge DFS benefit, and things have really come over there. So the crux of the debate basically, and I'll go to Dr. Ghanshyam for this. Do you think the ADORA is adorable? Because if you give surgery, then TKI, chemo, then TKI, the people relapse, then they get standard of care, then death, is equal or better than surgery, chemo, wait, relapse, Osimertinib, and then treatment death? What do you choose? Do you choose adorable ADORA or not so adorable?
I think so. We have to dissect. So as you rightly said initially, so we have to be in between, no? So we don't know the inside story or the story between these two. So ADAURA is adorable for those patients on the later stages. So it may not be for the early, so 1B or that.
Maybe for 1B or something. Doctor, I see Dr. Advait Gaur has joined. Advait, are you there? Yeah, Advait.
Yeah, Ullas, I'm there. I'm there. Hey.
Yeah, you have just come to the crux of the debate. So Advait, your comments about ADAURA, adorable or not so adorable?
I think, Ullas, it's about the optimum patient selection. When we are looking at a drug which is offering a DFS advantage now, and we don't know that there is overall survival, especially in a curative setting, yes, I would tend towards offering this treatment to patients, because we know that most of the patients would relapse post-adjuvant chemotherapy. And in that scenario, when a curative treatment is offering that kind of DFS benefit, it's very hard to really neglect that.
Okay. Now, this is especially for Dr. Herbert Loong. Dr. Herbert, which one will you choose? Money, luck, or love?
Wow. I don't know. Does money buy luck and love? Is that how it works?
I think I am sure you at home. So all of us would say love right now.
Well, I mean, I think going back to the main point, I think the ADAURA trial is compelling. I mean, if you think about it, taking a step back, I don't think we've come across any adjuvant treatments where the DFS, be it in all different types of cancer types, is such a large magnitude of benefit.
Yeah.
And I guess the biggest difference from why we're adopting, say, ADAURA as opposed to some of the other DFS positive trials in the first gen setting is because I think times have changed. We have more treatments available now for these patients if they progress. And I think patients are being involved in the regulatory and decision making as well. I mean, honestly, if you go ask a patient, your disease-free survival rate is significantly improved. Maybe that's what they want. I mean, overall survival, of course, is the gold standard. But if you tell them you're not going to relapse within the next 3 years or X amount of time compared with placebo, I think that's probably something that they're willing to take already.
Okay, Dr. Indranil has a point. Yes, Dr. Indranil.
Yeah, see, this is the era of shared decision making. So in this era, can we really withhold this kind of data from the patient saying that, no, this will not benefit you? We have to bring this to the discussion table and discuss with the patient and offer them, because unless we do that, we are withholding significant information from them.
I totally agree with you. I mean, this is a compelling data. That's what everybody basically says. Prabhat, the unblinding issue, I have looked at the unblinding issue. Will it change anything?
It might actually. It might change because once you unblind, a lot of placebo group might switch over to Osimertinib. But considering this, the huge difference is unethical not to unblind.
No, but Prabhat, I think if I understand rightly, and that's what Dr. Herbert also said, the patients and the investigators were not unblinded.
Now
the results which were unblinded.
Unblinded. I mean, now the data is out there in public domain.
No. The patient doesn't know whether he's taking placebo or Osimertinib.
He has all the rights to, because I mean, that was till the time they get the approval that they were the investigator only were unblinded.
Let me ask Dr. Herbert. Dr. Herbert, I mean, what does unblinding mean and what does it change?
Yeah, I think my understanding is the patient and the physician were not unblinded, but at the higher level in terms of the study design. So essentially AstraZeneca knows who has placebo, who has not. But I think the implication is, although the patient and the physician is not unblinded, with this compelling data, I would not be surprised if a lot of patients withdraw consent from the study. And then if they have financial means, especially in the US where it's now reimbursed, they would go for commercial stock.
So Dr. Loong, the point which was raised against this in the Med Twitter, in which you are very active also, I do follow you, was that, most of the patients have, the median duration was approximately 2 years. So if somebody has not taken Osimertinib in the placebo arm for, let's say, a year, a delayed adjuvant, would it really change anything? We don't know. So I don't think so. My understanding is that the unblinding has been done on the sponsor level. There is no guarantee that anybody who relapses will always get Osimertinib. There's no guarantee still of that. It was told to AstraZeneca to make sure that they provide, but whether they'll provide or not, we don't know. That's my understanding. I mean, correct me if I'm wrong on this.
Like these unblinding issues, I mean, like we had COVID vaccine trials, last year. So in those, like people who were on placebo, they had all the right to know once you had these results in public domain, whether they were in the placebo or because they have to take the standard of care vaccine. I mean, the same hold true for osimertinib.
You're right, but the issue over there is 2 years or 1 year, and I'm not sure they know. I mean, I would request the Astra people to tell us what exactly is happening. I am not so sure whether what's the right position is. Dr. Advait, you have a take on that, or Indranil Ghosh?
Yeah, so I really don't think that the patients and all were actually told about the unblinding. I think it's just at a higher level. That's what the impression that I get after reading the press release.
Vivek?
And it is something which is an ethical issue.
Vivek? Okay. Dr. Chintan?
Yes, sir, agree. So unblinding was only at the higher level. And if the patients and the physician are not aware, then I think we should be okay with that.
I think we would request AstraZeneca to tell us what exactly is happening with the unblinding. They need to show some clarity about that. I'm sure the clarity will come in pretty some time. The types of disease recurrence, even the distance and the local recurrence, everything is reducing, and that is what Indranil was talking about. 98% people not really progressing in the brain is a fantastic curve. I was just reading the Crown data. The similar data was there. And they said, the lorlatinib arm is not a curve, it's a line. So I think that's the same thing I will say about the CNS efficacy. It's a line, it's not a curve anymore, it's a straight line almost. So again, a rapid fire. Let me go to Dr. Chintan. He has spoken. Dr. Ghansham first. Dr. Ghansham, how will you manage people who are progressing while on osimertinib? Let's say you give osimertinib to someone. How do you manage these people who have progressed on osimertinib less than 6 months after stopping osimertinib? 6 to 12 months, more than 12 months.
So yeah, so again, so we have to look at the progressions. Is oligo progression?
No, it's a good progression. 2 in liver, 1 in adrenal, 2 in bone. Okay, I'll make it 6 so that you don't tell me oligometastatic.
So progression while osimertinib is going back to chemotherapy, going back to regimens like ABCP.
Okay, less than 6 months. Tough ones, no? That's why I put across over there, just in case your job sucks. Just see the right side of the figure. There are much more worse jobs people have. Advait is smiling on this. Advait, you came late. So less than 6 months after stopping osimertinib, what will you give?
I think I would look at repeating a mutation status again. We've seen that from the data that post osimertinib, many of these patients do develop other mutations, namely the MET14 skipping mutation. And yes, those drugs can be utilized in this situation.
Okay.
Other drugs like those targeting the exon 20 also can be used here.
Prabhat, less than 6 months, 6 to 12 months.
Yeah, less than 6 months of chemotherapy probably is not the resistance is not a typical EGFR driven, is something else. More than 6 month interval is something which should trigger me to reuse osimertinib here and see how long does it respond.
Okay,
I mean, this is arbitrary. We do not have any such data to define whether 6 months or 12 months.
That's why I'm chewing your brains. Dr. Herbert.
I mean, 6 months should be a reasonable time after stopping the treatment, because we know, like even in metastatic disease, when you stop EGFR inhibition before switching to chemotherapy, these patients progress rapidly. Yep. So, I mean, even a shorter duration of stopping EGFR inhibition is something which may derive a rapid progression.
Yes, Dr. Herbert, all 4.
Yeah, I mean, I think I agree with all the other panelists. I think the only question is, I will try to get a new biopsy. I mean, you do have small cell transformation, and also mentioned MET exon 14 skipping or MET amplification. And certainly there are other targeted ways. I mean, but if out of that, then the next really is Empower 150 or a moderation of that using, say, pemetrexed instead of a paclitaxel. That's generally our approach.
That's my a rapid fire question. Let me start with Dr. Chintan. If osimertinib is not available due to cost, will you give first or second generation TKIs?
So, sir, I will consider this. I will consider this when patient is not suitable for an adjuvant chemotherapy. For such patients,
okay. So if the patient is not suitable for adjuvant treatment, that means if mother and wife both are not there, you will look at someone else. No, all freedom at home. Okay.
Right.
Prabhat, will you give first second once osimertinib is not available?
Yeah, I would give you like an honest answer. What I have done in last last 1 or 2 year post ADAURA time. I mean, looking at these data has probably made us more wiser, and particularly doing debates with you so many times and having this discussion whether to give first generation TKI in adjuvant setting or not. Some of the high risk patients, particularly like if you have a patient with N2 disease and that too residual N2 after neoadjuvant chemotherapy, I mean, that patient is probably going to relapse very early. So whatever treatment you can use, use it early. And I have used that. So that's why I'm saying I would give you honest answer that I have used first generation TKI. As an adjuvant.
You have used first, second generation after ADAURA, but not before ADAURA.
Not before. Yeah, that's true. I mean, like, because really we've not, maybe I would say we are wiser after seeing these two trials, CTONG and
Ghansham, Dr. Ghansham, we all have to go for dinner.
Yeah, I will use for the first generation TKI.
You will use. So, you know, it's a very strange thing. I was on a panel 3 days back. Everybody said initially they will not use. But when I put this question, you know, everybody said they will use the first, second generation TKIs and post ADAURA results. Dr. Indranil Ghosh or Vivek or Advait?
No, I won't use. I won't use.
Great. Thank you.
Yeah. So stage 3, yes, but stage 1 and 2, no.
Okay. Advait?
I agree with what Vivek said. I would use it in a high risk patient. Yes.
It's normally good to agree with whatever Vivek says, no? I mean, normally the answer is actually right. So it is actually easier to say after what Vivek says.
It's not easier. I think there is a big area of gray in between which none of us know an answer for.
Dr. Herbert, what would you do?
Yeah, I think for high risk patients, probably worth discussing, but I guess we can't really compare. I mean, minus the cost and everything. I mean, Osimertinib is a drug that's much more better tolerated than say Gefitinib or Erlotinib, and putting them on for 2 years or 3 years with the acneiform rash, I don't know. I mean, that's not something that I particularly like to do for the patients. So I would probably still stick with not prescribing first or second generation TKIs in the adjuvant setting, unless in very, very extraordinary circumstances.
Okay. PD-L1 more than 50%, EGFR mutant, Chintan.
Anti-EGFR.
EGFR, no Atizo. This is an ASCA symposium. This is not a Roche symposium. Even if it's a Roche symposium, I don't think it is required. Okay. Toxicity, financial toxicity. I think we can skip about that later. Okay, this is a good one. I'll give it straight away, Dr. Herbert. What about uncommon and rare mutations? If you have exon 18.
Well, I don't think we have the data for that. And I think, you know, if we're committing patients for adjuvant Osimertinib, we really have to stick with 19 deletion and L858R, because that was the ones that was used in the study. I mean, a 36-month commitment to Osimertinib is a big commitment. Let
me make it very tough for you. T2, N2, you know, all the lymph nodes positive which have been taken out, ALK positive. Alchemist trial is not recruiting at your end. What would you do?
Well, so I mean, your question is, would I prescribe an ALK TKI as adjuvant?
Yeah.
No. Again, we don't have the solid data for that. And I think, if anything, we know that ALK in terms of survival stage for stage is better than, is probably the best. You know, if you're going to have a molecularly driven lung cancer, have an ALK, because that's probably the ones that has most treatment and best survival. So I would not.
Okay, this is interesting. Advait, what would you do? India, you can buy anything.
No, I would not really offer, because we've seen that even in the ADAURA, the uncommon mutations were just forming about 5% of the total study population. So this is we really don't know.
Let me see, Vivek.
No, sir. The data is not there, so I would be very skeptic. I mean,
okay. Ghansham, boss.
First of all, you won't get the PAP for this is not an approved indications.
It is your patient. It's okay. Your patient. He can buy. Tell me.
Some of the other patients are high risk patients. So maybe a food for thought.
Okay. So food for thought is always what I give to Professor Malik. Professor Malik.
No, I'm not really. The activity of Osimertinib in uncommon mutation is again questionable even in metastatic setting. So whether it would result in similar amount of benefit in adjuvant setting is again, in absence of data, is difficult to say.
So I think this was my last slide. I have just put across pros and cons of ADAURA. Never seen before be a DFS advantage, HR ratio of 0.12, 2 years of 86%, only 2% recurrence in CNS, reduces distant recurrences. However, there are no OS advantage. Are we only delaying the inevitable? But for the patient, it's not very bad. Financial toxicity and tolerability for 3 years remain a concern, but it's a compelling data. I think we do need to discuss, especially in stage 2 and stage 3. And this is, forget about that. So ADAURA trial, depending on the way you look at it, whether it was Will Smith hitting the other guy for this thing at Oscars or him winning an Oscar. As I said, there is one truth to the right and one truth to the left. Let's take our own truth. With this, thank you. Thank you all my panelists for a wonderful discussion. Enjoyed a lot. Thank you.
Thank you. Thank you.
Thank you, Ullas.
Thank you so much, sir. So requesting you to give the closing remarks.
This was a stump. I didn't realize that I had to give that also. Okay, it was a fantastic discussion. It was a fantastic entire program, especially all the Indian speakers and especially Dr. Herbert Loong, who gave a very elaborate, in-depth analysis of Osimertinib in stage 4, stage 3. And the panel discussion where people really had to listen to my poor jokes and still smiled and answered it very nicely was icing on the cake. Thank you. I have a feeling, you know, Osimertinib is whether you, it's like in stage 1, whether you like it or hate it, you can't ignore it. The data is too compelling, especially in stage 1, stage 2, stage 3. In stage 3, we have the lot of results that are going to come up. In stage 4, I don't think there is a doubt that Osimertinib is the front runner. Looking forward to life beyond Osimertinib, we now need to find out mechanism of resistance. How can we even improve? Because 3 years is not enough now. We want LX trial. We want more. We want EGFR mutant people to live for more than 3 years, 5 years, 7 years, 10 years. And really hope when the COVID is done and we all meet in physically, the survival will be much more better. With this, thank you. Thank you everyone for attending the webinar. Thank you.
Thank you so much, sir. So with your permission, I may end the meeting.
Thank you.
Thank you.